Well, that idea sounds familiar. Yes, I came up with this idea because I think it's really the fastest, the least expensive way to characterize the vulnerable patient. People who are coming to get their exam or have come to get their exam, they were not aware that they were going to die tomorrow or have an event next few days. They gave blood draw. I mean, we had blood draw, they gave blood stored. We have measurements from them. We even probably did imaging, calcium score, other things. This data currently exists. It's already available. We don't need to go and do a study. We just need to find these data and connect the dots and do analysis and let machine learning learn the pattern that exists in these individuals. I do believe or expect, along with some other cardiologists, that these patients don't just die with a heart attack out of blue. Yes, it may appear to others that they were healthy people just suddenly dead, but there are some underlying pathology going, and there is a footprint of those. We should be able to do a good detective job, the same way that FBI does a detective job and finds a bomber in 3 days with connecting all those clues. We have clues in blood, circulating molecules have information, imaging, general information about the person, and other things that are available to us. We need to be able to connect those dots. Again, these are not many people. In larger studies like Framingham Heart Studies or MESA, there are only less than 100 people in each of those. So we have to go around the world. I hope that the NIH or a nonprofit organization or funding organization or a charity person will have enough funding. This is not very expensive, but this project unfortunately is still not done, despite the fact that I brought the idea to a large group of doctors. They were all excited. They thought this was a good idea. It was not funded by American Heart Association and Google, but we're hoping that we will find the funding for it. And if we have that, not necessarily for next few days or week, but it would be great if we have an annual prediction. Tell the person that based on what we gather from your blood and your imaging, your anything, maybe 20% chance that you're going to have a heart attack in the next 12 months. That's pretty high. That's very high, and that will translate to actions. Those people will do something to prevent their events. We hope, I mean, NIH has some budget issue or has had. We hope NIH would consider this as really pressing area of investment. You know, NIH, despite the budget cut, spend money on all kind of things. If you can identify indicator of short-term risk and alert people and move them to do something about protecting their heart, why not? So I hope NIH listens and funds such a unique idea. Well, yeah, if we are able to identify people who are going to an event within a few months or a year, just like cancer, what would a cancer patient do when they find out they have a lump, or their biopsy came out positive, or a mass was found in their CT scan? They go do more intensive or accurate diagnosis, and then they take actions, whether they go under chemotherapy or surgery or a combination. In our case, there are other things we can do. I mean, there are some very simple things you can do. If I know that I'm going to have a heart attack, or I'm one of those very, very, very high risk, I will not take my chest discomfort lightly. I won't treat it like most people do in this country. It's still the time from feeling something funny and unusual, and it's not classic Hollywood chest pain that you suddenly die like this. So most people come with some symptoms that are not classic, and even if they have a slight chest discomfort, they think they're not related to heart. Most people think heart disease is for neighbor. over some big fat guy. They don't know heart disease mostly kill people that are not big fat guy or other characteristics. So heart disease affects most people. If they knew that they were going to have heart disease based on this characteristic test, then they would have taken it seriously. National symptom to arrival to a hospital time is about 6 to 8 hours. Well, if you knew that you were going to have an event, the doctor put you in the very high risk list, you probably would go there in 5 minutes instead of 5 hours. So that's the minimum impact. The maximum impact is we would have new treatments come in because it's such a short amount of time. You can put one group on surgery, the other group on another method, and do nothing on the third group, and then compare them in less than a year. If we have this ability to predict events in such a short term, we can open doors to really new era in cardiology, because then we have new tools quickly developed because this distance is pretty short. 10 years, that's a long term, and that's why we don't have a lot of innovation in cardiology. I think that's one of the reasons.